Hello. Let's go ahead and get started here. See how we can share with you the documents and we can get going with the lecture for this afternoon. So in this lecture, I will briefly share with you information about the impact of trauma and stress-related disorders. I will tell you a little bit about the history of post-traumatic stress disorder, PTSD, as a diagnosis, and will present on its prevalence. I will also share with you information to be able to define trauma versus early life adversity, ELA, versus PTSD as a syndrome, as a diagnosis. I will also focus more on PTSD itself and highlight latest finding on this topic. A lot of research has been going on related to PTSD in recent decades. I can say now that the confusing picture of this disorder is slowly coming to focus, and we know more about PTSD than we did 20 years ago. I will also share with you briefly information on etiology, comorbidity, and treatment. Trauma and stress-related disorders are a group of psychiatric disorders that arise following a life-threatening or traumatic event. They include acute stress disorder, adjustment disorder, and post-traumatic stress disorder, with this last one, PTSD, being the most challenging of these three disorders. So we will spend a little bit more time on this topic during this lecture. The component that's common in all these three disorders is having been exposed to trauma or traumatic event that was life-threatening. Trauma can come in different forms and in all phases. Child and early physical and emotional abuse, domestic abuse and violence, war-related trauma and terrors, and major natural and man-made catastrophes. And this year, we have experienced a collective upheaval that has led to traumatic events experienced by millions around the world. This experience was particularly pronounced and is still lingering for those who went through severe COVID disease and survived, and the loved ones of those who got severely ill or passed away in a tragic way. So, to have a clear idea of what technically we are talking about, let's define trauma. The DSM-5 defines trauma as exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways: directly experiencing the traumatic event, witnessing in person the traumatic event as it occurs to others, learning that the traumatic event occurred to a close family member or close friend. In addition to trauma, we should also consider another important source of stress that is directly related and relevant to mental and physical health, and that is early life adversity. Early life adversity can be defined as a physical, emotional, or sexual abuse and neglect before age 18. Research over the recent decade has demonstrated clearly that early life adversity leads to chronic states of stress with heavy consequences on health and mental health that can even be passed on from generation to generation through the epigenetic processes. This slide includes just examples of the public and mental health costs associated with early life adversity. As you can see, exposure to high levels of early life adversity can account for up to 78% of risk for different types of substance use problems and psychopathology. We have found that early life adversity also increases risk to initiate alcohol and illicit drugs at an earlier age. And we know that constitute an additional risk for continuation and for having to endure more significant consequences as a result of this engagement in substance use behavior. Another piece of research has shown that 75% of women in treatment for alcoholism reported a history of sexual abuse. Beyond the chronic effects on health, there are specific consequences that can be caused by exposure to traumatic stress. One of these consequences is developing PTSD as a specific syndrome or diagnosis. The history of this diagnosis became well known after the Vietnam War. In fact, at some point, there was a suggestion to call it post-Vietnam syndrome. Of course, people realized that this disorder was not unique to war or to Vietnam. The concept of PTSD has been expanded now to child and domestic violence and other types of trauma. So we define post-traumatic stress disorder as a mental health condition that's triggered by a terrifying event, either experiencing it or witnessing it. Grave physical harm is threatened or occurred during such an event. The primary symptom for PTSD include re-experiencing the trauma, for example, having distressing, vivid memories of the trauma that come as sudden flashes of the scene, accompanied by feelings of fear reminiscent of the original experience. You also see then avoidance of things that remind one of the trauma. For example, avoiding thoughts of the trauma or avoiding activities or situations that remind one of the trauma, amnesia for parts of the trauma, feelings of detachment from others, and feeling of numbness to emotions. You also see increased tenseness and heightened awareness, for example, hypervigilance, always being exceptionally watchful for potential danger. And you see exaggerated startle response, which is like jumping or reacting strongly when surprised or frightened. In order for PTSD to be diagnosed, the duration of these symptoms should be for more than 1 month. And these symptoms must cause significant impairment in function. Originally, PTSD was thought of as responses to a severe traumatic event that basically break the stress response systems. But it is clear now that this is not the case. Most people that are exposed to trauma do not develop PTSD. And those who do develop PTSD have some underlying physiological vulnerability that may lead to a failure in recovery after stress. We now emphasize the concept of recovery because it has been found to be more important than the immediate response to stress. So it's possible that trauma unmasks this physiological vulnerability. It's of course the case that trauma itself may alter these physiological activities. There are also genetic factors that may play a role, but also epigenetic effects that result from trauma. Other risk factors include exposure to high level of early life adversity. And this risk increases with the dose of trauma, as well as the lack of social and psychological support. We also now know that pre-existing psychiatric disorders can represent a vulnerability for developing PTSD. There are multiple neurochemical changes and correlates that are associated with PTSD risk, but we cannot yet draw a causal inference from the existing research. CRH is increased and it's associated with the cardinal features of PTSD, like hyperarousal, startle response, conditioned fear response. CRH is also very important for the stress response. That's why CRH has been targeted as a topic for research, looking for therapeutics that may be helpful with PTSD and other anxiety disorders. Catecholamines have also been thought to be related to PTSD. We know that norepinephrine is associated with enhanced arousal and with sympathetic nervous system activity, but also the flood of norepinephrine that happens during acute trauma may be responsible for encoding the emotional response associated with stress and trauma. It turned out that people with PTSD encode the trauma memory more strongly and accurately than people who do not develop this disorder. So more norepinephrine and less of the feedback break from cortisol can contribute to that. And in that sense, fear memory becomes highly encoded in the memory system of these vulnerable patients. Serotonin is also involved. Research has shown that 5-HT2 receptor, which is serotonin 2 receptor, modulate anxiogenic effects and turns up the effects of anxiety and fear. On the other hand, 5-HT1 mediate anxiolytic effects. There is interest in developing medications that target these specific receptors to try to deal with PTSD symptoms. Serotonin is also involved in symptoms such as impulsivity, hostility, aggression, and suicidality. PTSD is also associated with fewer GABA receptors. You may recall GABA is an inhibitory neurotransmitter that helps to calm down multiple systems. On the other hand, glutamate is increased. And you may recall also that glutamate is a stimulatory transmitter and can contribute to neurotoxic effects of stress and trauma. We also see in these patients lower neuropeptide Y, MPY, which is an anxiolytic. And that again kind of removes or attenuate a resilient or a coping chemicals that may help address this fear and the impact of trauma, which renders these individuals vulnerable for developing PTSD and concomitant anxiety symptoms. Endogenous opiates, which are also anxiolytics, are lower in patients with PTSD. So we know that during trauma and exposure to stress, endogenous opiates usually are released to help the person or the organism cope with this trauma, with this stress, and would alleviate or mitigate the impact of this fear. But in some individuals, it doesn't work well, and it doesn't work efficiently. And these individuals are likely to go on and develop PTSD. So thinking about the epidemiology, first it should be noted that the lifetime of exposure to trauma in the population is actually close to 75%. But not all of those who are exposed to trauma or were exposed to trauma would develop PTSD. The lifetime rate of PTSD is about 7 to 9%. And the 12-month prevalence is about 3.5%. In addition, in some groups, we see much higher rate. For example, we see PTSD in about 30% of combat veterans, also in about between 50 and 80% of sexual assault victims. The risk for PTSD is increased in women and younger people, possibly due to increased chances of exposure to high-risk situations and to increased vulnerability. The base rate can increase depending on location of events and proximity to these events. And in this year of the COVID pandemic, data are already coming out indicating a third of patients hospitalized with COVID-related symptoms meet the diagnostic criteria for PTSD. This slide here is from a study conducted last spring as the pandemic was spreading. So with the severity and the spread since then, this rate and the total number of affected individuals would be much larger. And the effect may not be limited to hospitalized patients, but to their loved ones and to health workers. There is very high prevalence of all sort of comorbidities with PTSD. Indeed, about 80% of PTSD patients have comorbid conditions. Frequently seen comorbid problems include depression, other anxiety disorders, and lots of substance use problems, in addition to somatization and dissociative disorders. Some PTSD symptoms are, in a way, normal in the short term, and increased rate of PTSD symptoms after exposure to intense stress and trauma would be expected. Therefore, we have this condition called acute stress disorder. The symptoms here are similar to PTSD, but for shorter periods of time. So that is an important distinction between acute stress disorder and post-traumatic stress disorder. Here we see these symptoms last between 3 days to 1 month. But in order for this condition to be diagnosed, it has to cause significant impairments acutely. So this is a diagnosable condition if these criteria are met. Some tips about screening for this condition. When you work with a patient who may have been exposed to a high level of stress or a traumatic event in their life, you would want to screen them for PTSD. Such an event may actually explain a lot of their presenting symptoms. I have listed here some of the questions that you could use to screen for these conditions and for identifying or differentiating it from other conditions. So for example, you would ask for any panic episodes. We talked about panic in another lecture. We may ask about worry, and we also ask them about any events that happen to them and still haunt them, which would tell us about if they are experiencing PTSD. From there, you can go to differentiate other conditions as indicated here. Although treatment options to date are only modestly effective, there has been a lot of exciting research to advance treatment and will likely make a big difference in the future. One of the available treatments is cognitive behavioral therapy. The treatment here focuses on the traumatic event and how thoughts related to it have affected the patient's life. Activities may include identifying details about what happened. As an example, a patient may have been blaming themselves for something related to the event. Treatment here would help them take into account all the things that were beyond their control. So with that, hopefully they can move forward, understanding and accepting what happened and appreciating that deep down it was not their fault, despite things that they did or did not do. The approach here also helps examine the thoughts about the traumatic event and figure out new ways to accept and live with this event, as well as address any intrusive images or symptoms associated with it. The context of the trauma and thinking around current danger are also addressed in this treatment approach. It may take about 8 to 12 sessions, and such treatment can have significant effects in addressing the PTSD long term. There's also education and what we call stress inoculation training, which can be helpful. It's in a way a type of cognitive behavior therapy where the focus is more on changing how you deal with the stress from the event. So a patient, for example, may learn breathing techniques and other ways to stop negative thoughts by relaxing your mind and body. It takes about 3 months of exercises to complete this type of treatment. Behavioral and exposure therapy can also be helpful. In exposure therapy, patients are brought by imagery to the traumatic situation and are asked to endure what they experienced while they are imagining that situation. Over time, the intense stress response is extinguished. It's almost like using the fear extinction response. It's been thought that prefrontal area of the brain is involved in this regulation. So in a way, you are exercising that area of the brain to extinguish this fear response. As you'd imagine, this type of treatment can be difficult, and you can see high dropout rate. That's one of the issues that we have with this type of treatment. There are now new videos and game exposures and virtual reality exposures that are being experimented with, and that they can be calibrated to help people and hopefully reduce dropout and to kind of modify as you go, modify the treatment protocol as you go. There's also an intervention called critical incidents debriefing immediately following trauma. It was thought to help because you basically ask patients to talk about what they just experienced immediately after an event or a traumatic situation. So that's called critical incident debriefing. However, recent research has shown that this approach does not work. Although it may help manage the acute situation, it does not help in preventing PTSD in the long run. There are some medications that may help patients, particularly by addressing symptoms such as nightmares and flashbacks, insomnia. They may also help with depressive symptoms. Multiple categories of medications have been studied in the context of PTSD. The start could be with medications addressing serotonin or norepinephrine. These are the SSRIs and SNRIs that we discussed before. And these include fluoxetine, so known by Prozac, paroxetine, sertraline, phenylephrine, and other medications. Other category include monoamine oxidase inhibitor, and as well as benzodiazepines. Of course, there are other mood stabilizers as well as other medications that address different systems like beta blockers and alpha-2 blockers like prazosin, clonidine, and gabapentin. It should also be noted that the FDA has approved only paroxetine and sertraline for treating PTSD. So although this list of medications may help, they are not officially approved or indicated directly for PTSD. Thank you, and stay well, and I will see you soon.